and she also is a member of Reverend Johnson Health Medical Group. We also have our sister Lisa Milli, who is an APP, which is a nurse practitioner as well, and she's been serving in women's health for over 30 years. And here, okay, we have our, okay, we have our Reverend Dwyer, who is also going to be a part of our panelists. She is a licensed clinical social worker, as well as she is on our clergy team here at Hope Church. So, and a breast cancer survivor. So, we're so happy to have this full panel here today. I'm going to sit down because my feet hurt me all. We sisters in here today, right? So we can keep it all the way real. So we're going to get started. We have, I have something I wanted to kind of share from a more clinical perspective. So according to Johns Hopkins, right, I just wanted to read this in regards to the benefits of screening and what a screening test does. So a screening test is done to detect potential health disorders and diseases in people who do not have any symptoms of a disease, okay? The goal is early detection, lifestyle changes, or surveillance to reduce the risk of disease or to detect it early enough to treat it most effectively. So, you know, in my practice, and my shoulder practitioner as well, it is very imperative, and, you know, studies have been, you know, very obvious about the benefits of screening and getting, having a, you know, a well-established relationship with a provider, because once you do that, you know, the outcomes of any potential, you know, diseases or disorders, they improve, right? Those outcomes, and that's what, you know, we want to see in our populations, not just, you know, our general populations, but, you know, the most vulnerable ones as well. And so one of our most vulnerable populations are women and minority women, okay? So our panelists today are, I believe, I'm sure they've had tons of experience with vulnerable populations, and they're going to, you know, be able to provide some of their input and their clinical expertise on these areas. So I have some questions, and let's just chat, okay? And so what we're going to do is we're going to ask some questions to our panelists, and then we will allow for any questions that are wanted to be asked to our panelists from our friends in the audience. Okay? We good with that, y'all?
Amen.
They gotta talk back to me. I'm sitting here like, you know, we're not family.
You good too? We
okay.
here.
All right. So, Dr. McDermott, I just want to ask you first this question here. As a surgeon, okay, and in your years of expertise, if you could just kind of give us some of your overall general input and insight on what breast cancer has meant to your population and the people that you've encountered.
Well, first of all, I want to say thank you for having me today, and I hope that whatever I have to say will at least leave you guys with, if nothing else, something to think on in the future to pass on to all your friends that are not here today. So I've been doing this for a long time, but honestly, even though breast cancer care has improved significantly in our population, there's still a lot of work to be done. And a lot of work to be done for a couple of different reasons, because we see breast cancer in a younger age group and a more aggressive type of breast cancer in our population. And a lot of the guidelines for screening would not capture that, and I'm sure we'll talk about that later. But, you know, the other issue is, of course, is that we tend to have more comorbidities because of structural racism that puts us in living in areas where we don't have access to as much healthy foods, recreational areas, as well as exposure to pollutants that impact our health. And just like we saw with COVID, we weren't able to get all the treatment because we're already disadvantaged. It's the same thing when you're treating breast cancer for the most part. So I tell people all the time, when they say to me that I've done everything right but I still get breast cancer, really, it should not be prevention. It should be an issue of mitigating your risk, because what's going to happen to you is already predetermined. I mean, the issues I tell people when you're born and when you die is already determined. It's how you walk through life that determines what happens to you. So if you do everything right and you do end up getting breast cancer, you're going to be in the best shape of your life to be able to get all the care. And that's what's the most important thing. So it's worthwhile doing everything right. It doesn't matter what age you are, what your family history is, because 85% of breast cancer is not related to family history. Even people that have the gene can mitigate your risk. And I tell people, I have people with the genetic predisposition that, I'll say they're not doing any of the extreme things to prevent them from having it, but they've adopted lifestyle modification, and that makes sense. I'm following them for 20 years, they still haven't developed it yet, because we know that meanwhile, genetics might load the gun, lifestyle's going to pull that trigger. So we really have to do everything we can and take agency. And that's the most important thing I'm going to be able to tell anybody today. It's nothing I'm going to do is going to make that much difference. I can treat you, and I can give you everything that's out there, but if you've done everything right, we're going to be able as a team to be more effective.
We're going to welcome our Reverend Dwyer. Wonderful ministry that she was able to be a part of. I so appreciate being a part of Hope Church. We have some of the best, talented, loving, and willing members here who also want to see our members as well as our community thrive and be in the best health and shape as possible. So I want to, since you just sat down, if you could just kind of give us a little bit of a snippet of what have you experienced, and what is your take on how this journey, this process has been for you?
Amen. So I believe when you say what I've experienced, we're talking about my journey through breast cancer.
Yes,
right? So for me, about 14 years ago, I was diagnosed with breast stage 3, in my lymph nodes, and that was quite a bit of a shocker. Considering I had been to the doctors a couple of years before that, and they said, "Oh, don't worry about it, everything's good, you got that dense breast thing going on." Okay, little did I know that was not a good thing, right? And so, moving forward, I've always talked about how to advocate for yourself, but nonetheless, I had several surgeries, infections, and breast on, breast off, all kinds of things happened that really took me for a loop, not only in my personhood, but in my womanhood, and I just thank God for one wonderful woman. I'll always thank her as a part of my journey, Reverend Dr. Glover. She called me to her office, and I walked in there, and on her board it said, "I shall not die, but live and declare the works of the Lord." And I continue to recite that song and live that. And so, a long story short, after following the directive of the doctors and all the chemo and all the radiation and all the after treatment and all of that, with mixed feelings from hearing and from what you should do, what you shouldn't do, the Spirit of the Lord said, "Follow the treatment and continue to believe in me." And so I did. So I believe that prayer and medicine go together. Prayer makes medicine better. And so I'm here today to 14 years later, to give God the praise and the glory for working through doctors and Sisters Network of Central New Jersey at that time, Sister to Sisters right now. And so I thank God for the community. Amen. And for physicians and for praying folk
Amen. Lisa, I'm going to jump over to you and pick your brains a little bit about what are the screenings for cervical cancer and uterine cancer, and if you could just kind of give us a little bit of a difference of what's the difference between the two cancers.
What I want to start to say is thank you for having me here. I also want to say that the reason why I'm so huge advocate for women's health is because I was actually raised in a Pentecostal church. I was in New York City, and I was never taught about my own anatomy and women's health. Never. And then, because I was supposed to get married, right? And then I wasn't also supposed to get an education because I was supposed to get married. But I fought my way, and eventually I went down the street to Rutgers undergrad, and that's when I realized the importance of women's health. I was able to advocate myself. I became a sexual health advocate. And this was when during HIV was like huge. And so I then came to realize that there's so much that I can give with my education to give back to the community. So anyway, so I've been doing women's health for over 30 years in many capacities, but again, I'm just here I'm just happy to be here to share my knowledge now. Screening, the great thing about cervical cancer is that we know the major cause for cervical cancer, which is HPV, the human papillomavirus. We now have a vaccine. And in terms of screening, there's multimodal ways to screen for cervical cancer. So one is HPV vaccine. It's given to young, both boys and girls, to try and mitigate this infection. We know it's an infection that is then transmitted later on in life, but it's really important to get our young people vaccinated before any type of sexual activity. And then once they are now of age, then to do pap smears. So these are, pap smear is a test that is done in your gynecologist's office, very easy to do. And then the second way is to test for HPV once you're, again, of another age, usually around age 30. Things have progressed in the last 20 years. I've been doing GYN oncology for almost 20 years. So I've seen the progression of how things have changed, especially for cervical cancer. So for uterine cancer, it's a completely different physiology. But to be honest with you, the main culprit is obesity. We do see, especially in our women that come into our office that are obese, having extra weight does elevate your estrogen receptors, and then your uterus, the cells start to grow, and then women experience abnormal bleeding. But for women that have abnormal bleeding, it could, they need to be ruled out whether it's uterine cancer or cervical cancer. So uterine abnormal bleeding is also a sign and symptom of cervical cancer as well.
Wow, that was very informative. No, that was very informative, and it's factual, right? So, ladies, it's important that you know your bodies, and that, if there's anything that's abnormal, that you don't wait. One of the worst things that you could do is just say, it'll get better. I'm not gonna worry about it right now, or I'm too busy, or I don't have time, or I'm just gonna call a friend. If your friend don't have no MD or APN or some type of clinical expertise behind their name, they're not your friend. Not for that. So, they're not Dr. Google, exactly. Do not ask Dr. Google, okay? So, we try here to advocate, for our members to please, get your annual, physical exams. Go and get, if you feel something that's not right, or if you're thinking that something may be, possible, go for some type of evaluation so that it can be properly diagnosed and you can get the treatment, ahead of time, or as early as possible, so that it will help to improve your outcomes. So, can I add something?
Yes, you can.
So one of the things that I see a lot in my GYN oncology practice is that women that have gone through menopause and then they start bleeding again. And women think, oh, this is a great thing. This is my period. It's my hormones. Yay, I'm a woman again. I see this all the time. And bleeding after you hit menopause is completely abnormal, and you need to get evaluation. So I just need to spread that word that, as you know, it's really important to know like your menstrual cycles and if there's anything that's off kilter, a little bit abnormal, bleeding in between your periods. Like let's say you have your periods and it's like 5 days and now it's 10 days and it's heavier. Or now you're like, yes, my last menstrual period was at age 48, but at 51 I'm not bleeding. It's not good. So please get it checked out.
Absolutely. And so, Dr. McDermott, Dr. McDermott, I'm sorry. I want to ask your perspective, your question. I want to ask your opinion, and for you to give your perspective in regards to these various screens that we're talking about and how you've seen them affect populations that are in minority communities, like the black and brown communities.
So, are you specifically talking about the recent recommendations that came out?
Recent recommendations and some of the hesitancies that, are being seen.
All right, so there is a committee called the U.S. Preventative Task Force that basically looks and gives recommendations based on epidemiologic studies and on how to screen for things like breast cancer, as well as other diseases. And their last recommendation was in 2016 when they recommended women should start to get screening mammograms at age 50 and get them every 2 years. And that has never been basically embraced by people that are treating breast cancer, radiologic societies, because we've always said that people should start screening at 40. About, say, a week ago, they finalized their new recommendations because they saw from 2015 to 2019, there's a 2% increase in breast cancer in women between the age of 40 to 49, and so they have embraced the recommendation for breast cancer screening to start at age 40, but every 2 years. And not to screen women over 74 because there's been no randomized studies, which is what we use to make recommendations, that looked at a significant amount of women over the age of 74. And they also talked about that whole breast density thing where there's no studies to show that there's any benefit to doing additional testing like ultrasound or MRI for dense breast. But, and these people, to be clear, they're not making these recommendations, and they're, well-recognized people for the most part. They're not in the business of taking care of breast cancer. But they're from, well-respected institutions across the country. They have no financial incentive to make these recommendations, but they're not looking at the big picture. Right. And I say that because, first of all, to start, we know that breast cancer in our population occurs at a younger age. We know that with dense breast, mammography by itself is not going to be good enough. And, if you're going to get breast cancer around the age of 40, you're not even getting screening mammograms. So there's got to be more to it than that. So what basically in American Society of Breast Surgeons, of which I'm a member of, and people are in the breast cancer or the radiologic screening part of this field, our recommendations are that we don't look at age to determine what happens, okay? Because we know that you could be 70, 80-year-old and in number, but physiologically be a 60-year-old, right? So in terms of when you stop doing screening mammograms for older women, if your life expectancy is less than 10 years, or you're in a nursing home, or you've got all these debilitating diseases that you're not going to be able to get any of the care anyway, there's no point in putting that person through unnecessary screening. So that's what we use as how we make a determination as who needs to continue screening over a certain age. But if you're an 80 or 90-year-old and you live independently and you're doing everything, why should you stop when you've been taking care of yourself well? And it's funny that I don't have those recommendations for men, but that's another story. Okay. Now, the other thing is that in terms of when you start screening for younger women, we still don't look at age. Our recommendations are we do a formal risk assessment for every woman over the age of 25.
Wow.
Somewhere between 25 and 30, but 25 preferable. And when you do a risk assessment, you're looking at certain things like, family history. When we talk about family history, it's important to know that the family history that's significant, because I see this all the time in my office. People tell me, oh, my cousin had it, my great-grandmother, whatever. The only family history that's important is our first-degree relatives on your mother's side, which is a mother, a sister, a daughter, okay? And on your father's side can be a second-degree relative, like your father's sister, okay? Simply because your father could have a gene and not exhibit breast cancer. So that's where on the father's side, a second-degree relative becomes important. But on the mother's side, the first degree. So, third degrees, great-grandparents, they don't matter. The other thing is how many benign biopsies has somebody had, because that also impacts on their risk. What were the results of those benign biopsies? Were there any abnormal cells? Okay. And in addition to that, any family history of male breast cancer. 1% of men have breast cancer. So if that's in your family, that's an event. Ovarian cancer at any age. And if anyone's ever had any gene testing, what were those results? Using that formal risk assessment that determines who is at average risk, who is at increased risk. And there are different categories of increased risk. There's increased risk because you've got a genetic predisposition. There's increased risk because based on the amount of biopsy, the density of your breasts, you have a risk score that says that we need to screen you a different way, okay? And so that's what we use. We use risk assessment, and there are multiple risk tools. They don't all work for African Americans or anyone with any sort of genetics from the African diaspora that fed the slave trade, but the one that works best for us is the Yale model. And basically, if you do any of those risk assessment, if your score is over 20, then you need to start getting mammograms at 35 and MRIs alternating every 6 months, because your breast is going to be dense and you are going to not miss some things on mammograms. If you don't have a high risk score, but you've got dense breast and you're getting your mammogram starting at 40, you should be getting ultrasounds, because you still need another test to find things that mammograms are not going to find. And so average risk, age 40 every year, because we know that you can have what we call interval cancers, okay? So we can't wait for 2 years. And the fact is, they look at survival to say, well, it doesn't make a difference if you find it in 2 years versus, 1 year. But survival is not the only thing we should worry about. If you find it early, then you need less mutilative surgery, 1. You might not need chemotherapy, and your survival, particularly for us in the type of, we've got a 25% chance of having that triple negative, the most aggressive breast cancer. The point is that we are going to have a better survival if we find it early, because stage to stage, survival is impacted. So for all those reasons, they can say whatever they want. It's important to get that risk assessment, because risk is what determines when you should be screened. It's not an age number.
Wow.
All right.
So ladies, I think that Dr. McDermott, she definitely reiterated and hit home on the importance of the risk assessment. So you all have homework.
Let's have her questions.
Yeah, you have homework. Yes, we're going to have some questions, but I want to give y'all a homework assignment. When you Monday morning, I need you guys contacting your primary care providers, your GYNs, and you're asking for an appointment so that you can get your risk assessments evaluated if you have not already done them. Because as we could see, and as Dr. McDermott, she pointed out that the earlier you get these the risk assessment done, the greater your outcomes, and the probability of things working out for you increases. Okay, so. Yeah. Oh,
absolutely. Both of you said something so I've told my story many times in many places for many reasons. But today, sitting here and hearing all this information again, while I'm so grateful for the lives that my journey touched through preaching and dance, through Sister to Sister, you were at an event that I was at, and you said fear doesn't change the outcome. Right? Right, and so I always told, that was years ago, you were somewhere at Deltas or something we were doing. And, but then as you were recounting all of this, the bleeding, having to get a D&C, you know what I'm saying, right, and clearing out the lining of the uterus, all the you know, I didn't have to go through all that. Because of the way physician biases and the way people look and see us as women of color, I didn't have to get my breasts removed. I didn't have to be walking around trying to figure out how my clothes were going to fit and someone needing to tell me how to use prosthetic devices so I could keep my clothes up and so I could feel normal and still today, you know, sharp pains coming through the body 14 years later. Just sit somewhere. I've learned to let other people see me respond to it, but it still happens. It didn't have to happen, so I am so grateful. Yes. So grateful. Because I went at 40. Because I didn't know my family history. After I got cancer, to find out my mother's several siblings died before 60. And on my father's side, 2 or 3 of his sisters died before 70 from breast cancer. So my children, my daughters, are now on early risk assessment, and we're watching, and I took the genetic testing, but then I took it again based on, because the first one wasn't suited for my makeup, but then a black doctor, I'm just going to say, he said, let me do the test again, but there's one more suitable, and he ran the genetic testing again on the 10th year, and so we're hearing some really good stuff, and God gets the glory out of the work and my survival and my overcoming. Yes. But it don't have to go that far.
Amen. The other part of your homework is to find out your family history.
Yes.
Because when I sit down with a patient in the office and I ask about family history, they don't even know what their grandmother died of, what their aunt died of, and it's also paternal family history, like you said, is just as important as your mother's history. You know, to your point, you know, the other thing is that, you know, when it comes to genetic testing, you know, originally the genetic testing was done in the 1990s with white Caucasian women. And so the genes that were actually identified at that time were specific to Caucasian women and then Ashkenazi Jewish women, and then now it's really important that we do genetic testing because, you know, I know I'm here to talk about cervical cancer, but the other thing is uterine and ovarian cancer, you know, because there could be another gene that may be in your family that maybe has not been identified because of your family history and because of being black and brown, those variants have not been identified in the literature. So the more people that we test, the more important it is so that way we can help each other.
Wow.
So we talked about when genetic testing came out. So we know genetic testing came out in the 1990s, late 1990s, and, you know, I guess Angelina Jolie made it popular. But the problem is this, is that even though genetic testing has been updated, only 2% of what's in the genetic database has been contributed by African Americans or anyone from the African diaspora. So at this point, it's still not helpful to us because when a lot of black and brown people get tested, you get what we call VUSs, which is variants of uncertain significance. And the reason why we have VUSs is so we don't have enough people to tell whether or not it is really significant. And so, you know, when we talk about the whole disparity of healthcare, is that yes, studies have shown that, you know, black and brown people are not approached to being studies as much because the biases of the physicians, not necessarily because we refuse. And a lot of times because of the way it's, you know, they don't really bring it down to your level so that you can understand too. So there's a lot of physician bias. And 3, you can't help but be suspicious because of our history as well.
There you go.
But what I have to say, even after COVID, when people refuse to get it, believing all the stuff you see on TikTok or whatever, is that when people are flying all over the place in minority neighborhoods to get vaccines, it must be good, because otherwise they wouldn't be caught in places like New York lined up. But we're refusing to get it. So let's face it, what we have to do is we have to realize that now we have representation. And I see it all the time. I'm listening to her talk, and I see young women that are curable, and they'll decide to do something holistic because they don't want medical treatment, because they're going to do some sort of cleansing, or they're going to take some whatever it is. And it hurts me to see that, because a lot of times I see primarily in our population. Why are we allowing this when there's a cure? And I say to them, I didn't get this knowledge by accident. Someone allowed me to have this knowledge to be here, to be helpful. So it's not by my own power. So, allow me to use it, which I think is really sad. But I see it at least once a month. I see somebody who says, I'm not going to do anything. I'm just going to pray. And then a year later, they're dying from this disease that was curable. And it really hurts me.
Dr. McDermott, I just want to talk about that for a minute, because that is one of the reasons why we do see higher numbers of chronic diseases and things that can be preventable in our communities. Would you say that that is because of mistrust? Do you think that it's because of misinformation? Do you think that it's because of social media and, outside influences? Do you think, what do you think, what has been some of the feedback of your patients that you've seen? And Lisa, I want to get your feedback on this also. What have been some of the biggest barriers that you've encountered? Because maybe those are some of the things that some of the, people the women in our audience may have experienced, or they may have, heard things that have, caused them to say, I don't know about that. I don't think that's right.
I think it's multifactorial. So let's put it this way. Definitely mistrust, because we've got all the studies on birth control that did in the Latino woman, the studies on chemotherapy that was also done, the Tuskegee studies, all these other things, right? So government, medical facilities have had history of experimenting on people that they consider to be more dispensable, right? And then there's also a lot of that, and now that there's all this fake information on social media, and people, I think, with access there, they don't know how to figure out what is a reputable source. And and then Dr. Google, we know, and it's crazy that I spend so much time trying to argue with people about what is real and what isn't real. And, honestly, sometimes I just don't know where to start. And to be honest with you, one of the reasons I gave up formal religion was because I found that a lot of people will use religious things as the reason why they're not doing these things. I'm like, I'm going to pray about it. Yeah, we're going to pray about it. So God should tell you, So people somehow are using some I can't do this. So only time I've entered a church more recently in the past 15 years is to do something like this, or a wedding or a funeral. Wow. Because I find that the more religious somebody is, what they call religion, and I applaud a church like this for being very forward thinking, is the more I find that people are resistant to treatment. Wow. And I don't know where that comes from, for the most part. I'm sure it's not God. At the end of the day, but you'd be surprised. There are just some people that, no matter where they are, it's almost like a cult. But I don't know what to do about it, to tell the truth. Because I said, if prayer was all you needed, I wouldn't have the knowledge. So that's pretty much how I feel about it.
First Lady.
I am so blessed and grateful to hear such rich information, rich conversation that God has allowed us. And I'm so thankful to our panelists. We have 2 members of Hope Church, so I'm thankful to y'all. I appreciate y'all. But I'm so thankful to our folks that have come in by invitation of the county to make sure that God's people gets education, right? And so one of the things that Hope Church, first and foremost, does believe in is prayer. And so the beautiful thing about prayer is it's communication with our God. And our God is the Father and the source of all things. But God is the God of wisdom. And because He has given wisdom, we have the ability to have such rich information from awesome practitioners who care about our people, who care about the kingdom, right? Whether we call it the kingdom or not, you care about the women who are in your practices, caring about those who are misinformed, misguided. And so here at Hope Church, we're incredibly thoughtful around making sure that our folks here understand that God created us as whole persons, like it says in Thessalonians, mind, body, and soul, right? Mind, body, and spirit. And it mirrors the Trinity, right? When you think of God in 3 persons, God created us in 3 persons. So I'm sitting here in awe of how God orchestrates things, how He's allowed us to hear the information. And I want to go back to a few things about screening, because I do think that that's important information. And so I encourage those of us who are in this space, right? You really are a living testimony. Yeah. Your life, your knowledge, your information, your testimony as far as your witness, right? Even wherever you are, you get to decide what your life speaks to. You get to decide the testimony of your life. So today, I'm asking that first the testimony be Jesus Christ above all. Second, I'm asking that the testimony be like, He saves your physical life too. He didn't come just so that we could, have this one way of being or understanding. He came that we might have life, and life more abundantly. And so today, as we walk in healing, right, when you all were talking about bleeding, all I could think about was Pastor Milli's sermon this morning, and the one with the issue of blood. I would like to draw our attention back to some of the screenings. Dr. McDermott, you mentioned a risk assessment as a part of the risk assessment, something I had never heard of. I want to ask you to repeat that. Lisa, if there are some specific screenings that you could tell us, because some of us, we're going to have to take notes and go back to our providers. I mean, seriously, I'm for real. I'm going to have to type it in my phone and say, hey, I was at this conference at Hope Church over the weekend, and I had a wonderful APN there. We had Dr. McDermott, and she's a leading surgeon, and I would like to know, could you please tell me what this assessment is? Because time to have it, right? So can you draw our attention back to some assessments, back to some screenings, and just kind of gear our minds and hearts toward the information that God has allowed in this place today. Thank you so much.
All right, I just started. So when I talked about risk assessments, there are multiple tools, and these are mathematical models that has been developed by different physicians throughout that do breast cancer care. And what they've done is that they've looked at, how many benign biopsies a person's had, family history, okay? What was the results of those benign biopsies? Were they totally benign? Because benign biopsies on a spectrum. So it could be totally benign, or it could be some abnormal cells. So it's still benign, doesn't need anything else. So when you look at all that, the results of that, so you're putting the pathology report as an input into this mathematical model, then you come up with a score for the most part that tells you, in breast density, that tells you, are you above 20? And if you're above 20, that means that you need to get not just mammogram, but you need to get, mammogram and either MRI if you've got a high-risk family, or if you don't have a high-risk family, mammograms and ultrasound as part of your annual screening. It also tells you what age to start screening, because if part of that screening also shows that you have one of the genes, we talk about the genes like, she talked about getting updated testing, because now we have a panel. We do a 30-gene panel, because we know it's not just BRCA1, BRCA2. We've got, it's like 9 other genes that inform breast cancer care, some of them with greater significance than the other. So if you have 3 of the ones with the highest penetrance, which means that we need to consider surgical management if you're at the appropriate age, because you do outgrow your risk. So a woman with a genetic predisposition under 50, your risk is different from a genetic predisposition over 50. So what I'm going to do for you is going to depend on that. That's based on all studies. So if you have any of those genetic predisposition, then we talk about when you should start your screening at 25 with MRIs, start your mammogram at 30, and then we encourage you to complete your childbearing by 40, and suggest if you need to take your ovaries taken out at that point. And for women that present later, there's also a way to prevent propagation of these genetic predispositions. You know, we could refer you to an in vitro fertilization doctor. They're able to do egg retrieval, determine which one of those eggs have the faulty gene. And when you decide to have your family, reimplant those genes, the eggs that don't have the faulty genes, you're not passing on to your kids. So we've come a long way scientifically. So the lack of not wanting to know is actually not good on multiple levels, because everyone wants to make sure their kids are fine. And if you can find out what you have so that your child doesn't have to have it, and their children don't have to have it, what better gift is that? You know, so saying I don't want to know doesn't change what you have. I mean, basically it just means that you know you can do better, have a better outcome on multiple levels.
Wow. And was there something called the Gale?
The Gale model. The Gale model is one of the risk assessment. There's like the Tarakusic, but the Gale model is the one that works best for African Americans because it takes into breast density, it takes in some other stuff that aren't in the other models.
Perfect. Thank you so much.
I learned something today. I've never heard of the Gale model. I'm going to look into that. So that I can share that with, with my patient population and the women that are important in my life.
And it's on the computer. I mean, you could look up the Gale model on the computer and actually, put your stuff in it yourself or whatever it is.
Wow.
Because, I mean, not anything, but I find out a lot of gynecologists aren't doing these. I mean, if you're in a GYN oncology, like, that's her subspecialty, they do it. But your regular gynecologist, I mean, I find that a lot of times they're just, I guess, overwhelmed with delivering babies that they're not doing that sort of stuff. And, you don't need a breast specialist for it. It can be done easily because these things are available on the computer.
Wow. That's
And
good.
the Gale is spelled G-A-L?
G-A-I-L.
G-A-I-L.
Thank
Okay.
you. That's great.
So to your point, the regular GYNs are seeing 4 patients per hour.
Wow.
And so they really don't have the time, unfortunately. By the time you come, it's very fortunate that when you come to see me, I do have the time. So anyway, but yeah, because I am very self-specialized. So in terms of screening, the one thing that I do hear about is fear. Women are very fearful to go to the doctors, or they're just fearful of what the results are. And so they never go back for follow-up. And one of the things that I always advocate for women is, when you're getting a pap smear, ask about your HPV, ask about your risk for HPV, and your doctor will be able to kind of discuss with you at what point during the trajectory of your screening we should be doing HPV, because that also, the recommendations have changed as well. And are you also a candidate for getting the vaccine? Because it is right now FDA approved up to age 45. Gardasil 9, I want to just emphasize that, 9. So there are 7 strains of the HPV virus that causes cancer, and the 2 main ones are 16, 18. The majority, 70 to 80% of cervical cancer is caused by HPV 16. So, and the other 2 is for genital warts. And it's not just for cervical cancer, it's also for head and neck cancers, anal cancer, penile cancer, vulvar, vaginal cancer. So it's all for any mucous membranes of both men and women. So I just want to emphasize that, and we have seen tremendous progress that actually. So I always hear about it, in journal articles that cervical cancer is going down in this country, in the United States, because of HPV. vaccine. And the other article that I just read is that actually, as a good point of the HPV vaccine, is that the country of Australia, which has higher rates of vaccination for HPV, have seen lower rates of preterm labor.
Wow.
So, which is huge, and especially in our African American, we are, I'm not African, I'm Puerto Rican, but,
The diaspora.
So, preterm labor is also it's a high risk condition in women. And so it's so important to get screened for the HPV virus.
Can I say something about fear? From the, in personal journey, we're talking with women who encounter breast cancer and are sharing their stories. Fear. We have these really odd sayings when we've gone through breast cancer that sometimes folks would rather die with them on than live with them off. Wow. Right? And it's for real, because when they was off, I didn't know what to do. I didn't know how to get my clothes on. So the fear is real. The hair is gone, the breasts are off, and then I got a pimple, and I said, okay, God, if I gotta be bald, I can't have a pimple on my face too. And that was a real conversation I had with God about the pimples. I was like, okay, you can't do both.
One or the other.
But it's we don't know how to imagine or reimagine ourselves outside of how society has painted us would be what it means to be a woman, what it means to fit in, what will our spouses think, and how will we be in relationships. It takes on a whole new narrative when you start changing some things that you were born with, and the world says that this is woman and this is not. And so that is, I think that was I'm telling you, I couldn't even believe some of that, and I'm just like, come on here, but the fear is real about not being seen as a woman.
But I'm going to tell you something, though. That fear is cultural. I find that if I were to take different cultures, the conversation as to whether you've got hair, you've got breast, or whatever it is, I'm not going to have those conversations with everybody. I mean, and so I think that it's a broader question. We have to learn to stop defining ourselves in terms of other people. And, I mean, fortunately, that's a problem I've never had. But, I grew up in Jamaica, and I came here at 15 to go to undergraduate, and I knew I was fabulous. No one needed to tell me that. And I've always lived my life that way on my own terms. So at the end of the day, I had to learn to understand that fear is how do you define yourself? Because every single person, whether you're bald or whether you don't have breasts, are beautiful. It's like, I tell people all the time, get a nice tattoo. Rock that bald head with some big earrings. Let me help you figure that one out, because it is a lot of cultural stuff that goes along with it. Some people will have a mutilated breast and will never let me take it off, but I can give you some beautiful breast, after. But it's just the concept that these are not my own, and I want them no matter how diseased they are, and no matter how sick they're going to get me. So I think we have to really change that conversation, And so that's where the men come in, our other, sisters and all the family members and all that sort of stuff. And I tell people that's why I no longer embrace the European hairstyle, because I'm going to be part of that.
I just want to say something in regards to fear, and I want everybody here to hear me. The Word of God says that the only thing that we can incorporate with fear is that we are fearfully and wonderfully made. Mm-hmm. And so there needs to be no fear. There needs to be, more focus in our daily activities, our lives, and our attention towards our temple, and this temple that God has given to us. As a mother of 3 daughters, women's health is important to me. And so, I wanted to ask our panelists if we can talk in regards to some of the concerns or some of the things that you're seeing in the younger populations, and how intentional mothers, caregivers should be for their young daughters. or regarding your young
Can I
daughter's
also say
health.
sons too?